Okay, so thank you so much for having me. This is what this pic. You can see the slides now, I guess. Is that right? You see the
Yep,
slides?
yep, it's all
Good.
good.
Okay, so there's a picture of me when I was wearing a suit and a tie and having a proper haircut and all that kind of stuff. And I'm actually pretending to work from the office, but I'm really at home. Um, I was lucky enough to be invited to the Huddle in September 2021. So I dug out the slides. Oh my gosh, I'm telling them the same things or I'm doing something different. I think I have to do a little bit of both because I'm guessing that some people will have heard my talk way back when. If you did, you might have forgotten it all and deleted all that memory. But obviously, other people might be new to this. So I've kind of tried to put new stuff in and still leave some of the stuff that. So apologies to those people that have seen some of this before, but hopefully a little bit of a refresher. So my name's Owen Johnson. I'm at the University of Leeds. In the university, I'm Director of Impact for my school, which is computer science. Two things that are relevant is that I help run a training centre for artificial intelligence in medical diagnosis and care, where we're training 50 PhD students in AI and how you can apply it to medicine. So I can think that fits in a number of ways, which I'll try and explore. The other thing I'm doing is I'm program manager for a Masters by Research program that's in data science for healthcare. At the moment, we're running it just for NHS England employees, but I'm redesigning that. There's a possible shameless plug for a redesigned Masters program coming soon. It's a Masters by Research, which means it's mostly a big research project. So people are interested in that, then my email's here, and Rachel knows me and can put you in touch with me. What I found in my old slide decks was this is what I was going to talk about in September of 2021. And I'll come back to this. I've really introduced the fourth bullet point, introduced process mining, the tools, and some guidance on how we can use it with electronic healthcare records is the kind of key one. Last time I looked like I talked about safety. This time I wanted to sort of put more of an emphasis on AI because I think it's kind of important to see where the government are thinking about AI and maybe how we can kind of ensure that sort of data analysts have got a kind of valuable role in that sort of new NHS as we move towards it somehow. I think the first bullet point is the key one. Process mining is like data mining, but with a focus on delivering and understanding business processes. In our world, we probably call those care pathways, or any kind of process that happens in a hospital or in healthcare environments. So what I want to do, so I'd quite like to say process mining is new and it has to be done, or process mining is actually much more important than data mining. I haven't done slides that say that. I'm not going to be that radical yet, but my personal view is process mining has so much more power than data mining. And if I can start to kind of persuade you of that in the next half hour, great. Okay, so what I want to do, this is my summary for today then. I think there is a sense of urgency with the new government that things like waiting lists must be addressed. We must have faster, better, more effective care pathways. There's also a sense they're not actually going to put much more money into it. So we've kind of got a very interesting dilemma in that there's a government that really wants to help, but isn't necessarily going to give us any more money to do that. And so they keep saying work smarter. And work smarter, I think, comes down to how do we use our NHS data to do better. And I'll try and persuade you that data mining doesn't have the answers. And as data analysts and data scientists, understanding process mining and bringing that into your existing tool set will be valuable and useful to you. And the rest of it is just sort of talking about some examples and some methods. So I'll try and finish in about 25 minutes. Give us time for some thoughts and reflection. If, on the other hand, you want to interrupt with questions or probably can't see if you put your hand up. So, Rachel, could you, if people do put their hand up, Rachel, could you interrupt me?
Yes, of course.
Is that okay? All right,
Yes.
good stuff. Okay, just to set the scene, process mining is not new, but it really surfaced around about 2005, so 20 years ago. And really from this guy called Will van der Aalst, who's Dutch, who's known as the godfather of process mining. He wrote the definitive books on process mining. He runs 2 annual global conferences in process mining. There is a book on process mining healthcare. It's a little bit old. Since that book was published, me and a group of other academics around the world have been running a international workshop on process mining in healthcare. And so I'm one of the international leaders in process mining in healthcare, along with a really nice community of people who are mostly from Europe, but also from the Americas and Asia. And so I'll come at the end to the kind of process mining in healthcare manifesto that me and others have written. But we've been running an international workshop in healthcare process mining for 7 years so far, 8 years coming up. Next one is in Uruguay. If anyone wants to do a fantastic academic paper and go to Uruguay to present it, then that's in October of this year. Okay, so the idea of process mining is you discover what the real processes are by looking at something called event logs. And for those that have not seen this before or can't remember my talk previously, I'll kind of show you a little bit about that. So I'll kind of give you the kind of simple intro to process mining, but it's much more than just process maps. So if you this diagram is kind of trying to say, well, traditional data science has a load of stats and algorithms and data mining, machine learning, and predictive analytics, and so data science on the kind of world of data science can benefit by linking to the world of process science. So there is a world of process science called operational research or business process improvement, process automation, workflow. There's a whole load of people that just do process science. So process mining then is trying to act as a bridge between what we might see as traditional data science and what we might see as traditional process science. So things like process modeling, process improvement fit within a process mining framework. So there's a lot of potentially exciting things to do that to me are much more exciting than just chugging at the data. So this is kind of where I'm coming from and trying to summarize my kind of belief system, if you like, how I look at healthcare. And I kind of think of healthcare as a cloud. So this cloudy symbol in the middle is the idea that healthcare is a complex system. And in the academic world, we talk about complexity theory and wicked problems, and complex systems is a particular thing. Probably best defined by the fact that complex systems have non-linear behavior. Let me give you an example of non-linear behavior. Here's a nice simple system diagram of input, process, output with a little bit of feedback and control. In a linear system, if you put money in, like you buy more resources, you will get more things going through the process and you'll get better outcomes. So in a linear system, more money, resources, staff and assets go into healthcare, you'll get more patients with better health coming out. Sadly, in a non-linear system, there's no guarantees that putting more money in will lead to better outcomes. In healthcare, we should never tell the bosses this, never tell government this, but more money doesn't necessarily give better outcomes. What we probably need to do is think about how processes can be improved, how control and feedback can be improved, but understanding that healthcare is probably the most complicated industry or market or sector in the world. I don't think I've never come across anything as complex as healthcare elsewhere. So a lot of the traditional thinking about input and process output doesn't really work in healthcare. we need to be a lot more subtle and a lot more careful in the way that we use and think about tools. So part of what I'm going to do then is talk about the set of tools that I use. Process mining is the one that I want to talk about today, but process simulation is very closely linked to process mining. So I'll talk about the links. Process improvement is probably what the bosses and the government and the public want from us. They want better healthcare and they want our processes to be better. And then process modeling is the art of just drawing out, what we think processes are using post-it notes or UML or BPMN, if you're familiar with those, or just on a diagram. So we've got 4 different techniques and a kind of framework of input, process, output, where our feedback and control is probably data coming from the IT systems and control is management. And I want to kind of introduce you to the techniques that I use and try and encourage you to think about how you might adopt them yourselves. Okay, so I thought I'd start with last Tuesday. This is actually this guy on the top left-hand corner is a Leeds graduate, so we're really proud that he's got a nice proper job now. So Keir Starmer on Tuesday of last week announced a plan for change for the NHS, which was predicated on an AI action plan, which has got kind of 3 major headings. The phrase that's in The Guardian, I love this, and they're going to mainline AI into the UK's veins. Terrifying. I presented this slide to a research conference last week, and they were mostly AI people and mostly found it entertaining. The reality is that improving the NHS is a really, really tough job, and people have been trying for decades and decades. But great, great that there's a new initiative, great that there's a lot of enthusiasm, and the AI action plan is actually quite sensible and does look quite positive. Number 2, the second bullet point, I think is the one that's relevant for us. The public sector should rapidly pilot and scale AI products and services. So that means, and his examples in his speech were 50% healthcare examples. And so he and Wes Streeting are expecting us to kind of mainline AI into our processes. That affects us in that as data analysts, we're the people that curate the data, understand the data that's used to create AI. But it also affects us in that if AI comes into the NHS, we'll be expected to analyse it and evaluate it. So I'm going to talk about how the new government agenda fits what I think might be your day jobs and how we might help the NHS and the government achieve that. Interesting little aside that was in the government speech is that the UK is 3rd after the USA and China in its vibrancy of AI. So actually, kind of maybe they're right in that there's potentially we are actually kind of a leader in AI. Certainly for our size of country, we are developing better, smarter AI than other countries. Interesting thought. We'll maybe come back to that in discussion. What do we do? So I think the government's aim is summarised on this slide. This is where we are now: is large numbers of waiting lists, queuing for limited resources, and in some wonderful future, we'll be straight into a bed and we'll have loads of AI that's kind of helping us, and everything will be rosy. So somehow we're going to inject some artificial intelligence into all of this and create a wonderful situation. But to me, as an AI person, also a process miner, and I kind of see this process mining as a way to evaluate AI. The big questions are, what type of AI are you talking about? Where's the data coming from? You guys as data analysts will be the people that know that the data is tough to work with. So if you're taking data and taking AI and training it in America, it's not going to work for British NHS hospitals. obviously, or British patients. Like, yeah, also obviously. An AI that's not properly trained and using bad data will have a whole load of risks and bias in it that are really not good. Um, Relevant to what my talk today is, where would you put AI in the process? So if you put AI at the beginning of a healthcare process in early diagnosis, then hopefully you reduce the number of people that get more seriously ill. But it does mean that suddenly you get more people coming up to the hospital because you've diagnosed people earlier. So where AI goes matters. If you put it at the end of a process, then can be helping, colon surgery, colon cancer surgery. And but ideally you stop people from getting colon cancer in the first place. So how would you actually really do that? Where would the users use it? How would they be integrated? And again, risks and biases all the way down the line. So what I'm going to talk about is a partial answer to what the government want to try and achieve, and also hopefully connect to kind of data analysts, data science roles. So here's my starting point. Kind of just a series of statements. If you kind of hopefully agree with most of these statements. So when people use computers to do complex business processes. Computers create data. Data can be used to create algorithms. If you want to have impact with AI, then you need to implement it back into real world applications. The obvious place to implement AI is in the computer applications that people are using to complete their business processes. So AI can be implemented, obviously, within existing computer applications. So that would mean within your Cerner system or your EHR or your order comms system or all those systems that are inside the hospital or inside the used by the ICBs, all those systems would have AI inside them. But that AI needs to be trained based on the data that was inside it for it to work. So yes, it can be implemented. And now the starting point, the next stage then would be people using computers with AI applications to complete their business processes. And that last bullet point, I think, is kind of the interesting one, is that if you do that, you just start again. So we've got computers with AI involved in them. Go back to the start, do it again, and just you can keep improving the AI that's inside our healthcare processes iteratively and forever. If we can create something that allows us to create a loop where we use data to develop AI, we put AI in, and we use data to evaluate the AI and make it better. So that, what I'm interested in is what's called a learning loop. We can, using the techniques I'm going to show you now with process mining, we can take business processes and data and produce a process map of the current situation. You can imagine that if you added some AI to that current process, you would create a different process that'd be slightly better. And we can create a process map of that. And interestingly, we can compare what the current with the future or the past with the present. So we can use process mining to evaluate the effectiveness of interventions in our care pathways by looking at before and after the intervention. So that's my starting point, which hopefully if you're following this and buying along with it, great. Here is, on one slide, how to do process mining. So apologies to those that have seen it before, but as a kind of, I think I can explain process mining at its simplest. It just walking you through this slide, because I think most of you are familiar with databases. So in step one, this is an American database called Mimic3, but it's what you'll see is an entity relationship diagram with a whole load of tables and links between the tables. You won't be able to read detail, but it doesn't really matter. It's an electronic healthcare record database. The bits that are in red, and again, you can't see them, but if you can see where the red bits are, those red bits are date timestamps. So they are records of an activity that's taken place in a hospital with a date time stamped on it. And that's obviously for a particular patient or a particular admission. So the way process mining works is you write SQL to find anything with a date time stamp on it that might be interesting and create Number two, an event log. So an event log is usually the subject ID there is patient, Haddon ID is admission. So just all the patients, all the admissions, what are the activities, and what time and date did that happen? So you can imagine that event log, if you mine an AHR, could be huge. It could be hundreds of thousands of transactions. Many of those might be very interesting, but many might be irrelevant. So there's an element of pre-processing that needs to go through and join things together, separate things apart, decide what to focus on, choose some time intervals, etc. But the end result is that you can put an event log into a process mining toolset, and I'll show you various tools in a minute. Those tools can produce a process map. So this thing on the bottom right hand side is a map of a care pathway that's got a start and an end, and you can see it's the darker colours mean that these activities take place more often. The thicker the line shows that this transition takes place more frequently. So you can see a basic pattern of a care pathway emerging from an event log taken from a database. So if you're happy with that, you might say, well, surely this is all simple then. All I need is EHR data from somewhere. All I need is extract the transaction logs, or the dates and times from that, create an event log, and then use a tool to create a process model. So yeah, in theory, that's simple. Those of you that have worked for the NHS as data analysts and data scientists will know that the data in our systems is far from clean, and far from easy to work with, which is why it's a tough job. But let me sort of give you some examples and talk about the challenges. So I think the first challenge is that there's a big gap between what really happens in healthcare and what the clinicians, or NICE guidelines in this case, think the pathway should be. So the pathways typically should be nice and linear, nice and straightforward, driven by protocols that clinicians have been trained in, given by procedures that hospital staff have been trained in. But the reality is quite a bit more chaotic. Somewhere in the middle of the chaos is an IT system. You can see it being used just here. That IT system will have some screens. People will use those screens to record care into the database. So this database is where we come in, and we can potentially use this data to look at the gap between reality, as the as is, and then the kind of theory, or what should be happening. And so, interesting way of comparing reality to theory, and somewhere in the middle is probably some kind of truth. So what I thought I'd do is I'd show you this example. If anyone has worked on this, could you put your hand up or say hi, or tell Rachel? So we did a project last year with NHS England and East Midlands Ambulance Service. I'm conscious I'm in the Midlands now. So some of you may be familiar. If you have comments, I'd be delighted to hear about it. So we looked at, I think, around about 3 months data from East Midlands on all their ambulances. The pathway of an ambulance should be simple. You should phone an ambulance, you go through some triage processing, an ambulance travels, they're on the scene, they put you back in an ambulance, they take you to hospital and hand over. So that, in theory, is how East Midlands Ambulance Service should look if we did process mining. So here's what we found. This is the reality of East Midlands ambulances. It's what we call a spaghetti diagram, for obvious reasons. It looks like a plate of spaghetti. You've got the little blue boxes are the activities, but you've pretty much got anything could happen from any order to any order. There were 152,000 trace variants of basically 152,000 emergency calls. And this is a record of all of them. So process mining, take those event logs, put it into a tool, you get this kind of spaghetti. It took Alex, who's one of my PhD students who was seconded to NHS England full time, took him around about a month and a half to tidy the data to the point where it kind of looks much neater. This is the end result then of a month and a half's worth of tidying. In discussion with East Midlands Ambulance Service and NHS England team. What we've got here then is something that looks back to more like that standard flow of ambulances having an incident through to turning up at hospital. But what Alex did, which I think is relevant to everybody really, is that instead of having one endpoint, he created different outcomes for all the different possible ends. So no treatment required, patient refused assessment. So he created, the last step was always the outcome, and everything prior to that step is the pathway. What he was then able to do was to use machine learning to do prediction based on what had happened during the pathway. So Alex took the events during the ambulance's visit or ambulance trip and used those to predict the final outcome, along with demographics like age of patient. What he found was that the best predictor for the outcome, around about 30% likelihood, was the initial clinical category of the call, which is this first one in the decision tree at the top. That's sensible, because what that means is that the triage person who was answering the phone categorized the call quite accurately. So here's a kind of process mining where we've done process mining and we've kind of created a process map and then tidied it, created outcomes, then done machine learning. So this is the kind of thing that I think Wes Streeting wants. I think this is exactly what the government are looking for. This is the kind of stuff that I hope that you guys have pretty much the best position to be able to do, because you understand the data better than anyone else. Okay, so here's an example that I did show previously. This is my work on Leeds Hospital, Accident Emergency Department, and I'll kind of just highlight the few. This was in the days of 4-hour waits, if you remember those. This histogram here for A&E time had a median of 3.9 hours. Those of you that remember 4-hour waits will remember that basically everybody gamed it to the last possible minute, and then you got seen just before the deadline. If you missed the deadline, if you'd been waiting in A&E more than 4 hours, you'd broken the target, in which case there was no point seeing you. So this to me, this meant, my interpretation of this was, if I went to A&E at Leeds, if I wasn't seen, I'm going to wait 3.5 hours at least. If I wasn't seen after 4.5 hours, I might as well go out and come back again, because my chances of being seen down here are slim. Okay, so 4-hour waits did drive some perverse behaviour, but on the other hand, it kind of worked at the time. What we also did was we mapped out the pathways for different hours of the day, and for most of the day, the pathway for A&E is quite linear. But in the night time, and in particular, we kind of narrowed this down to 6 p.m. But the night time, chaos breaks loose. All sorts of things happen in all sorts of different orders. So even to the point where a bed is requested before the patient has been seen by the clinician. And in some cases, bed is requested and they've left the A&E. So we mined by hour of day and then went back to the A&E manager and said, what happens at 6 p.m? Because all hell seems to break loose at 6 p.m. and chaos ensues. And the A&E manager said, well, that's easy, that's the shift change. And so, lesson for me, time of day matters a lot. Day of week, similarly, matters a lot. Bank holidays matter, winter and summer matter, because winter flu can hit at different points. So actually, process mining, the process itself changes at different times of day. So it's very organic to understanding processes. So that's kind of some of my lesson on lessons I've learned on process mining. Um, the kind of approaches we've done is that this is chemotherapy at Leeds Hospital. What we've realised is that there's different types of patients. There's patients in the green area who've had 6 cycles of chemotherapy and been discharged and everything's fine. There's people who have not completed the 6 cycles of chemo. There's a lot of people, sadly, who've been back for multiple cycles. And then there's some people that have very, very long history of 10 years or more of very, very complicated care. So it kind of suggests that the patients themselves are not homogeneous. That you kind of have to split, as well as splitting by time, you need to split by type of case patient, complexity of case patient. So in this case, we decided that those people that had very, very complex care, there's nothing we can do to statistically. They're all very, very individual. So we kind of, from the point of view of process mining, focused on normal, people that were seen too quickly, or people that didn't complete, people that had more complex cases. So another way of looking at process mining by kind of complexity of patient. We also looked at the influence of things like government policy on time. So this is the prescribing of antidepressants in GPs in Leeds. What you'll see is that there's a massive spike in depression in Leeds in 2007, and a pretty hefty spike in the prescribing of new antidepressants in Leeds in around about 2007. So you might think, why did Leeds get very depressed in 2007? Did they get relegated? No, it's actually QOF, for those who work in primary care. There was a whole load of government incentives to record both and to prescribe new antidepressants. So time in process mining matters as well. You can't just take buckets of data without really understanding what happened, what kind of events might have shaped that. So I think my conclusion is that process mining is rather hard. There's a chunk of things like the types of data, the way people use systems, the complexity of electronic healthcare record data, how it changes over time, and how data quality changes over time. And then what do you extract and the choices of that, and obviously the fact that we're working with people's personal data and how sensitive that is. So having ethics and anonymization, and then understanding what it is that we're actually trying to mine, deciding on what cases are of interest, what events are of interest. So hopefully I've kind of given you a quick overview of what process mining is. It's relatively simple on face value, but the complexity requires experienced analysts, people like yourselves, to be able to do it well. Come back to the care pathway improvement. There are 3 ways of using process mining. We can use process mining to discover what's currently done. We can use it to see how well it conforms to what should be done. And then the interesting bit, which fits with the government's agenda for AI, is we could start to use it to think about what is best to do. How could we improve processes in the NHS? And part of the way that I would advise people to do it is care pathways are very complex, but they follow standard patterns. They're either linear, or they're a cycle, or they're referrals from one swim lane, one responsibility area, to another swim lane or responsibility area. And then there's things that happen in parallel, like diagnostics are done while you're treating a patient. All the way down the line, though, patients are waiting. So in answer to the government's concerns about how do we reduce waiting lists, process mining will allow us to find the points at which people are waiting, what they're waiting for. And then there's a very simple thing called the theory of constraints. The theory of constraints is as simple as the performance of every process will be limited by one thing, one constraint. That if you can find that one constraint that limits the process, and if you can remove that, so let's say it was not enough people on reception, put more people on reception, then the rest of the flow will improve until you hit the next constraint. So the theory of constraints is there's always one constraint that's slowing down the process. Find it, fix it, then you're going to find the next one. Then you do that again. So there's a way of improving processes, reducing patient wait time simply by finding the bottlenecks and fixing them. So some of the things we've been doing are applying complex pathway analysis to do comparisons. So I'm going to flick through these kind of stuff. We have done process simulation, where you build a process map and then run a simulation of it. And we've then looked at the proposed new pathways. And so this one, the proposed new pathway is this extra bit of diagnostics. And by putting costs onto simulations, we can cost pathways and see whether proposed new pathways have better outcomes and better financial savings. So where I'm going with my academic agenda is to link this kind of real life through IT systems and data through event logs to process mining to produce this kind of detailed process analytics and process models. But the work my team is doing is to fold process models into process simulation tools so that we can do what-if analysis and fold in observations of current practice. And the bit I'm working on with right now is to try and work out how to take process simulations, create synthetic event logs, feed those into process mining, so we can round trip between process mining and process simulation based on more informed by observed process until we get very effective simulations of the pathway and then use those for what-if analysis. So what if we introduce AI here? So that's kind of my academic side. I have produced a methodology, which I can share via Rachel, which is called ClearPath, specific methodology for process mining in healthcare. It's based on PM2, which is a standard methodology for process mining, and that was based on CRISP DM, which you might have learned as a kind of standard methodology for data mining. So, so I can share the paper on how to do that. And the other thing I can share is what's called our process mining manifesto, where we identified characteristics and challenges in healthcare doing process mining. And so that's a kind of worldwide manifesto for process mining in healthcare. So I can share those via Rachel after the talk. And I kind of finished with some EHR challenges. So I think you guys know more than me about how hard it is to work with healthcare data. So I want to I'll leave this slide also for this is the slide with the different tools. Celonis is probably the market leader. They are going to run a process mining and healthcare course for me. It should be free. It should be either on, we're not sure whether it's going to be online or at Leeds. So I can, Rachel, if you don't mind, I'll kind of pass you details. If there's any free courses, I'll let you know.
Absolutely.
Fluxicon Disco is easy to use, download free for short volumes. So if you want to play with it, Disco's nice and easy. But if you are a R programmer, then BoopR is the process mining toolset for R. If you're a Python programmer, then PM for Pi is the Python toolkit. And I've put some other links there. So Rachel, that's kind of, I think that's me talking for too long. Me skimming over a lot of stuff, but I'm kind of happy to kind of stop. I've had a sort of stunned silence, which I never know is whether people have gone off to make coffee or.
No, everybody's clapping. Everybody thinks that
Okay.
was wonderful, and it was. No, that was really that was a really interesting, and well, I think what it does is share the what you were saying at the beginning about the power of process mining, because and we didn't really get into it, but the comparison between, and we don't need to, between that and data mining, and why process mining is maybe so much more meaningful to people because they can see how it relates to pathways and how data links together, because it takes that step forward, doesn't it? No, that's a thank you so much. That was fascinating. And you're doing so much in this area as well. And there's obviously I need to be doing a little bit of work so I can get to Uruguay. But there's I've got a little
No, let's all go. I mean,
a little bit of homework to do there. So I'm sure, hands up, who else is on board? Let's go as a team. But yeah, no, that's really great. I do have, Owen, a couple of questions on the Menti, so I can just share those
yeah,
with you. They were
yeah,
they were posed earlier on as you started to talk, so you might have covered some of them as you went through. But let's start with that, and I'll see if I've got time to throw in my penneth worth at the end as well. Here we go. So this is I've got 10 points or questions, and this normally puts them all on the screen at the same time. So there's something happened
okay.
during the Christmas break, so we'll cover them one at a time if that's okay, and they'll just be in the order that people have put them in. So here's your first one. I'll let you read
Yeah,
that.
okay. So Rachel, what I'll do is I'll share the slides with you. I'll find those two
Yes.
papers, which I think they're academic papers, but they're not
Yeah.
particularly hard to read, so I think they're quite
Okay.
accessible. And what I'll
Okay.
also do is there are some online courses from I think LinkedIn Learning and Coursera, a future learning.
Okay.
So I'll find the links for those and I'll send them to you, Rachel, and then if you can circulate
Oh,
them.
absolutely. No, absolutely. Because I think one of my questions was literally, how do you get started? You're sitting there, you've never done this before. It's an approach that is going to work for some of the challenges that you've got. So it's sort of how you get started. And I imagine some of those learning materials, as well as um, the examples which you've shown in your presentation, will help people realize what is in front of them is perfect for this approach, and maybe sort of how to take those first steps.
And then the last bit of advice, I'll just get anything that works. Just take two or three events. Just
Yeah.
produce a
Yeah.
map.
Well,
Just small baby steps. Baby
yeah,
steps is fine.
yeah, proof of concept, isn't it? And I
Yeah.
suppose with many of these things, it's like getting people involved with it as well, who aren't analysts, to be interested in how it can be used, and maybe the potential impact that it could have, because that's more than half the challenge sometimes, is what to do with some sort of great analysis once you've actually achieved it. You need to be able to have an impact. So there's a couple more questions as I'm sort of walking through these. So
Oh
are you
yeah.
linked with HDR Midlands?
Right, yeah, can be happy to be.
Yeah,
Happy to do that.
I wonder if my colleague online, if that might have been Kevin, I don't know, but it could be anyone else. So I will connect you afterwards.
Yeah.
Clearly, a connection is
Yeah.
is needed there. Okay, I think you have answered this.
Probably helps with that. So process mapping, to my mind, is what I would do with post-it notes on a whiteboard or a pen and
Yeah,
paper, and then process mining is the technical side. But you
using the
can you
data.
can you can put a map into a process mining result and see how the process that's mined maps to the process that you've modeled.
Yeah,
I
and
didn't
that
cover that, but that would be there is a lovely synergy between the two.
And it's yeah, but there is, and I suppose you kind of demonstrated it by comparing the nice the
Mm.
guidance in terms of a pathway to the actual what was generated from process mining. So, and yeah, you could use what you could kind of like a subject matter specialist saying, this is what I think the pathway is, and they could do sort of a compare and contrast as to what actually happens, because no doubt they're going to be different. That's that one. So we've kind of we've touched on
Yeah,
that
same
a
same
couple of
answer
times.
then for
Yeah,
that.
yeah,
It
yeah,
says if our approach to assessing the optimization very well. Yeah, probably. Just had stress. I know, I agree. Yeah, I don't think I can say much more than that. If you worked in healthcare, you know this. You kind
yeah,
of create it. It's. So I think the main thing is making sure that people don't assume it's easy. You know,
yeah,
kind of just I put an extra nurse on this ward. Why aren't you doing this? So we kind
yeah.
of have to explain to people that it's not as easy as it might seem.
And that is the challenge with a lot of this, isn't it? You can give people the answers, but the solution is never ever easy in our complex world. But what it does do is it gives people much more robust information and evidence as to what they the more likely solutions to situations that people are faced with. But it's never easy, and it's
See,
many things are slow to implement.
one thing you can do, which might be a great thing for the Huddle to do if people are interested, is that you can map your service and get
Yeah.
friends in other hospitals or other parts
Ah,
of the UK to also map their services, and you can compare and contrast. So
yeah.
comparing how we run our ward,
Mm,
well, just comparing different wards, to be
yeah.
honest. And you'll get variation between different wards or different locations, different hospitals, different healthcare organisations, and you can ask yourself, is that because we're genuinely different, or is that because our patient demographic is different? So there's no one optimization, but there is a lot that you can learn from the best
But there's
practice of others.
Yeah, no, definitely. We'll do that. Maybe I'll start a process mining group because I'm very interested in
Okay, well,
this topic.
I'll join.
Uh, I
Go
realise
on, we've got four more and we've run out of
yeah,
time, obviously.
I've hit 12.
Yeah, I do.
This was one of mine. This was one of my
I
questions. So,
love systems dynamics. It kind of
yeah,
does, and I am really interested in how it does. It's whenever you got a loop. And I
yes,
use simulation.
yeah.
Simulations are kind of those process simulations are systems dynamics, I guess, really.
Yeah,
So,
so it's very
yeah.
much part of improving the system. Do you link with NHS improvement community, for example, NHS impact and beyond?
Not, no, I should do. NHS England has a small team of three process mining people as part of their data science team, and I'm working with them. So I'm kind of working, but not. I should do. Yeah, right. Thank you.
I know somebody who's in that area, so I might see if I can put you in contact with them. A
That'd be great.
couple more. I'm being very generous today. I normally shut the door at 12
Yeah,
o'clock,
no.
Owen. Yeah, you must be very engaging and
Well, I think numbers are dropping.
no, well,
I've
that's
lost
fine. That's absolutely
lots of
fine.
people.
It's everything is all recorded, and if I leave the
Yeah,
best to, I bet if I leave a nugget till the end, then they
there's
will
still
simply
lots.
have missed it, or they can come back and just go to the end. The joy of being able to look at the recording is I get chopped out at the beginning, so people don't have to listen to me jibber jabber on about this and that the other, unless they really want to. Okay, so this is interesting. You may not have heard of this, but the links with the National Competency Framework developments to get a
Yeah.
competency set and become part of the learning offerings mappings. Have you heard
Yeah.
of the
No,
National Competency Framework?
No, I know about it. I need to have a look at it, don't I, and see whether
Yeah,
it's maybe a bit dated now. I mean,
it's
process mining's been
well,
around for 10 years, and
okay.
I'm still trying to explain it to people.
Well, the great thing is that the National Competency Framework is current because it's being updated all the time.
Ah, right. Okay.
So this will be your opportunity. I can send you some
Yeah.
information or a link
Yeah.
to that. Really important. So anybody in this field, if they can actually describe their role in terms of the National Competency Framework and build in their sort of skills or desired skills in these kind of areas, then your efforts to increase the coverage of this and get people using this approach will be more systematized and more recognized, I suppose, as a thing as part of that. So that's
Yeah.
that. And then just two more. So can NHS teams do this for themselves? I'm guessing
Yeah, no,
yes.
definitely. Yeah, I mean,
Yes.
I'm here to help. Partly here to sort of say, hey, let's try and do this. But I think you can.
Yep.
I think there's a lot of value in using the huddle to share. So if
Yep.
one NHS team does
Absolutely.
it in Midlands, let's share it with the others and show and tell between each other. So
Absolutely.
how about this as a challenge then, Rachel? Invite me back in
Okay.
a year's time, and
Okay.
everyone present what they've done.
No,
I'll be the
that's a great.
audience, and everyone else present.
I'll just book it in, and I'll get and
Yeah,
that would be
that'd
and
be cool.
actually what I haven't done for a bit is have people, have 5 or 6 people just with a quick sort of
Yeah.
update on and it could be I've started to think about it or right the way through to we've developed this, we've got everyone on board and kind of thing, because the some of the challenge of introducing a new process or a new approach, A, you might have to learn about it. B, you have to get kind of like agreement to people that I've got to take time out of my day to learn about this and implement something new and things like that. So, but there is something about persuading those around you, your team, your line manager, and others that you would like to do something. And the power of the analyst in that setting might depend on various things, um, but yes, giving them the tools to do the job. In academia, there is time to do this. What did I just say?
I know, I
In
know.
healthcare, no one is employed to do this. Three
Yeah.
people. Every ICB needs a solution architect. Interesting.
I agree. I
Interesting.
absolutely agree. I think, and it's trying to persuade the bosses that investing in intelligence to
Yeah,
understand how the NHS works
yeah,
is going to pay back more than investing in one
absolutely.
extra resource. So we
Absolutely.
always have to articulate that. I mean, the NHS England team for process mining is great because there's three of them. There's only three of them in the whole country that are in the national team.
Yeah.
And arguably there should be 30 or
Yeah. So
more.
that
And they should be in a position where they can help you guys. But they.
Absolutely, absolutely.
Uh,
And if people around the country, whether it's in the Midlands or others, if they have sort of like a specialist interest in this, or is it some skill set that
mm,
a particular team is developing? I mean, they can maybe do some of this sort of analysis on behalf of others as well. For example, in the strategy unit, we do work on behalf of others, so
mm,
it could work like that. But ideally, it's just having that recognition
yeah,
that for analysis, for approaches to improve, there needs to be that investment of time and skills, developing skills with the analysts who are out there who understand the data and who
yeah.
want to adopt different approaches and don't want to have to sort of go outside for someone to say, well, to share this with them. So that this well, let's see what we can achieve on that front as well. So just nearly there now. See, I've gone past 12 now. I don't, it's fine. I'll just go on forever now. I'll just get to the end
This
because
is like the 4 hour wait. Once you've broken the
yeah,
target, you're driving
it's
it.
do you
Yeah.
know it's exactly the same. It's exactly the
So
same.
yeah, I think so. But I think linked healthcare. I mean, I've worked in linking health and care data for 20 years, but I think there's lots of people that can do that. And it's always about having a safe enough environment and having
Yeah,
sufficient levels of anonymization that you can link on patient ID. And if you can link on patient ID, the world is easy. And if you
yeah.
can't, because you're quite often not allowed to, then it's more challenging. But yeah, there's a whole. I mean, I'm happy to talk to people about what I know and what I don't know, and but many other many other people could help linking as well.
Yeah, I mean, I must admit, I thought linked health data would be like a done by now.
It's not.
Uh, no, it's
It, well,
way, way behind
just
what other
since
people.
we're overrunning anyway, the two challenges to me is firstly, obviously, can you link at all? But if you've got patient
Yeah.
number and in healthcare and social care, link
Mm.
the things, but they've got different geographical footprints.
Oh, yes.
And so a patient may go to Leeds or Bradford if they live in Pudsey.
Yeah.
And so I can't link Leeds to Pudsey confidently.
Yeah. No.
And also that situation changed over time.
Hmm.
And the IT systems that produce the data changed over time.
Yeah.
And patients themselves move around.
They
So
do.
the challenge with linked healthcare data is deciding what your scope is, I think.
It is, and yeah, like you say, we sort of acute services change over time. All health and care services change over time. Their catchment population is different. The registered population is different. The GP registered population is different from um, the sort of the geographical boundaries. There's there's all these things that sort of have to be sort of borne in mind and planned for and made decisions made from, and they'll never be perfect. But the link between health and care data is just like so. It was kind of like the ultimate aim, really. What happens before people go
I
to
think,
hospital and
yeah,
so on, and afterwards.
I think ICBs have got a huge potential role to play here, and the agenda of the shared data, federated data platforms is, there is a roadmap.
Yeah, yeah. It's not like there isn't a plan. It's just that I thought it'd be done by now, and how exciting that would be to actually have all that. But it's not. It's a work in progress. Just a couple more points. I think people are adding questions. They're tricking me here.
No, we're going to be here for hours. So I think we should. Well, okay,
No,
yes, you're right. I agree.
just quickly do these. So modernize,
Yeah,
oh, got rid. Yeah,
got
that's.
rid now.
I'm
Yeah,
sure. How local are the solutions? Can oh,
I love that. Yeah,
definitely this
I
one.
love that. Just
Yeah,
compare between friends It's a
Yeah.
great idea.
I think start small, compare between friends. We show people these sort of finished products, the examples, and it looks complicated and it looks like that's difficult to achieve and time consuming. But starting small, like part of a service and part of a trust, it'll be much more achievable. Like this is definitely the last one. I'm not going to allow anybody else to put
Good.
anything.
Yeah.
There's probably I haven't gone to the room for a bit. There's probably literally 3 people in the room. I'll go back and have a look and say,
26. So
yes.
we're down from 57 to 26.
No, here we
So
go.
thank
The
you for
data.
staying. Those people that are staying.
Yeah, it says the data is already linked. Some data is
It-
linked, some data is
Some,
not.
yeah, exactly. Yeah. I mean, we work with the data you've got,
Yeah,
and where you've got linked data, use it. Be aware of boundaries and times. But yeah, I agree. So I think there's loads that can be done. I think somebody highlighted the fact that as an academic, I've got maybe a little bit more time than you guys, and that you've always, everybody's rushed off their feet, and having a
yeah,
kind of conversation where you can say, look, we need to be able to learn new tools, upskill, tackle the big problems. But from the government's point of view, they want waiting list down.
yeah, yeah.
And how are they going
Link
to
it
do
to the
that? Well,
target. Yeah.
they're only going to do that if they listen to the data scientists.
Yeah, and we've had we've had people on here, and we did used to do training on theory of constraints, which went down really well. We haven't done that for a bit, and the queuing theory. We just need to link them all
Yeah.
together, and we basically have a solution in front of us. So but I think it's opportunities like this that just allow us to introduce analysts and others out there, just that there are actually some solutions which are going to work better than doing the same thing in the same way, because they've proven not to work. Look, here's me actually.
I think we should let people go, Rose.
I guess so. My tummy is rumbling. Thank you so much, Owen. We'll
Oh, it's been a
definitely,
pleasure. Okay, so the commitment, my commitment to you guys is I'll send my slides and the
yeah.
papers. Your commitment to me is I want to come in a year. I want to be invited in a year's time for you guys to
Yeah.
present to me. That's my
Okay.
challenge.
I've got somebody. I thought someone had a hand up, but I don't know if they have actually got a hand up.
No, I think we've run out of time. This is
No.
some applause. Thank you for the applause.
Yeah. Okay. Thank you very much. Okay, everybody. Thank you so much for coming, and I'll see
Lovely
you
to
in a
meet you
couple of
all.
weeks. Making data count in a couple of weeks. See you then.